As a gastroenterologist, it is my pleasure to discuss about one of the most fundamental procedures in internal medicine, the endoscopy procedure. We classify different types of endoscopy based on the area of the body we examine. We have the upper GI endoscopy, which examines the esophagus, the stomach, and the first portion of the duodenum. Then we have the colonoscopy. This procedure is used to inspect the rectum, the colon, and in some cases, the terminal ileum. In this video, we will focus on the upper endoscopy, or otherwise known as esophago-gastroduodenoscopy. It is crucial to understand what an endoscopy can actually do. Endoscopy is more than just a camera on a stick. It's a minimally invasive procedure performed under soft sedation used to examine the interior of the upper digestive tract. The instrument used is an endoscope, a flexible tube with a camera, a light source on top, and the ability to early diagnose and treat various gastroenterological conditions. We diagnose different conditions depending on what we see during the examination. We can see signs of inflammation such as esophagitis, inflammation of the esophagus, gastritis, inflammation of the stomach, or duodenitis, inflammation of the duodenum. Additionally, we can diagnose malabsorption syndromes like celiac disease, precancerous conditions like Barrett's esophagus, polyps, and even autoimmune inflammatory conditions like Crohn's disease. Then we collect small tissue samples called biopsies to confirm what we saw during the endoscopic procedure. We then treat different types of conditions. These conditions include internal hemorrhages of the digestive tract, a rupture of the gastroesophageal varices in cirrhotic patients, a bleeding ulcer, or a bleeding polypoid structure. Foreign body removal, objects like coins, fish bones, or even some foods. Tumor resection, especially precancerous tissue like polyps. This process is also known as a polypectomy. In some neurological cases, especially in patients who had a stroke in their recent past and now have alimentation issues, we can place a nasojejunal tube used for feeding. Now, let's dive together into a procedural walkthrough so you can better understand the whole process. The first segment we inspect is the esophagus. Like you see here, the esophageal mucosa is pink-red, and there are no signs of inflammation or masses that can obstruct the lumen. If we pay close attention, we can see multiple polypoid structures. We cannot tell for sure if it is something malignant or not until we see the results of the biopsies. Now we enter the stomach, and again, there are no signs of significant inflammation or occupying masses in the stomach. This place right here is the pyloric region. This is where Helicobacter pylori usually sits between the gastric cells. If we consider necessary, we take a biopsy used for a rapid urea test to see if the infection is there or not. We will go through the pyloric sphincter. Then, we will enter the first part of the duodenum bulb. After that, we will examine the second part of the duodenum. This yellow liquid you see all around the intestinal walls is bile. This bile is evacuated here to help digest the fatty compounds from the ingested food. After that, we will gently pull out the endoscope, we examine the intestinal mucosa once again, and we return to the stomach, passing through the pyloric sphincter. Then we will perform a U-turn move so we can clearly see the fundus region. We inspect this region especially in patients with cirrhosis for gastric varices. Now we will simply return to the normal position, and we will finish the procedure by meticulously inspecting once again the stomach and the esophagus. This is a shorter form of an upper endoscopy. Usually it takes around 5 to 10 minutes depending on what we find. So as you can see, using this technique, we can easily diagnose conditions like gastritis, H. pylori infection, esophagitis, gastric cancer, so on and so forth. A core skill in medicine is knowing when to order a diagnostic procedure. So pay close attention to what I am going to explain next. For patients who suffer from persistent upper abdominal pain or refractory gastroesophageal reflux disease, an upper endoscopy is crucial. Like we said before, it allows us to investigate pathologies like esophagitis, gastritis, or even peptic ulcer disease. Dysphagia is the clinical term for difficulty swallowing. A patient with dysphagia requires an endoscopy to evaluate for a potential mechanical obstruction, such as a stricture or even a tumor. Iron-deficiency anemia can be a sign of slow, chronic blood loss from the GI tract. So investigating anemia is a very important role of the upper endoscopy. An upper endoscopy is performed emergently in patients with hematemesis, vomiting blood, or melena, black tarry stools, to localize and control the source of bleeding. We also use EGD for routine follow-up. For instance, in patients with Barrett's esophagus, we perform serial endoscopies to monitor for dysplasia and prevent progression to adenocarcinoma. Additional preparation plays a big role in the GI endoscopy. Before the procedure, the patient must not eat for at least 6 to 8 hours. This is non-negotiable as it is critical to ensure a clear visual field and, more importantly, to minimize the risk of aspiration pneumonitis. We also must review their medication lists, especially antiplatelet agents and anticoagulants. Most endoscopies are performed under soft sedation, using a combination of a short-acting benzodiazepine, midazolam for anxiolysis, and propofol for a deeper, more profound level of sedation. While in most cases a very safe procedure, it's essential to be aware of the potential, though rare, complications. The most serious one is perforation, which is the penetration of the digestive wall. This is an emergency and requires immediate surgical evaluation. Other rare potential complications are bleeding after a biopsy or an intervention, or allergic reaction to the sedation medication. I hope you did understand how endoscopy works, and if you found this information helpful, please give this video a like, subscribe to the channel for more health insights, and let me know in the comments what other topics you'd like me to cover next. Thanks for watching, and we'll see you in the next one.